Okay. I have no financial conflicts of interest. We're going to talk about OCT and autofluorescence. I may discuss some off-label uses of medications. And before I get started, I just want to thank a couple of people. Chirag Shah, who has some of the images in here. The rest are mine. Number two, my residents, who always bring me really interesting cases. Sometimes not so interesting, but usually interesting. And I want to thank God for designing such an amazing structure as the retina, the most amazing part of the whole body. And Spectralis, or Heidelberg, for, yes? You can't see the retina without the cornea. Well, when the cornea is not there, you actually can still see it. So, very funny. And so, and Spectralis for making such beautiful images. Neither of these images is Spectralis, but they remind me that we in some ways, autofluorescence and OCT is dumbing us down like Google does. It makes us more accurate in our diagnostics, but it also makes us less dependent on our clinical exam. So I think I'm probably a worse clinician at the slit lamp than I would have been maybe if I trained 20 years prior. And I'm reminded of that when I go to Africa, and I keep on asking myself when I'm looking at patients, what does the ellipsoid zone look like? I'll never know. This is killing me. And so anyway, the patient on your left is a patient with vascular tortuosity. I thought this is just a beautiful image. And the patient on the right is somebody who came in to see me this week with a little bit of nyctalopia, some hemerolopia, 2020, 28-year-old female who had a perfectly normal fundus exam, but she's got these findings on her OCT, which you can see. Her ELM is a little bit grayed right in the center, and her ellipsoid zone is a little bit fuzzed as well. And so she's getting a workup done. Most likely she has a cone rod. She also says that her father, her paternal grandmother, and that lady's mother all had vision problems that started in their 40s. So spectral domain OCT is amazing. This is something that, these findings couldn't be seen on Stratus or time domain OCT. So let's talk about autofluorescence for a moment. Most of you know that autofluorescence refers to intrinsic fluorescence that's derived from something in the eye where we don't inject fluorescein or ICG or something like that. So for instance, I shine a photon of light at a structure. If that structure is fluorescent, it takes that photon, it has an anatomical conformational change where an electron jumps up in orbit, and when that electron comes back down, it spontaneously emits another photon of a different wavelength, and as far as I know, it's always a longer wavelength. So with autofluorescence that we use, typically it's a 488 nanometer wavelength light. With Spectralis, it's 532 with Optos. Goes in, creates this excitation, and we have a barrier filter so that before the light comes back to the charge coupled device or the CMOS or the film or whatever you're using, we're blocking out the original light, and we're only taking in this fluorescent light. And so you'll never see any shiny things. This isn't a reflectance image, so blood vessels are always going to look dark like that. They're not going to have that little reflectance where they curve like you would see on a red-free perhaps or on a color fundus photo. So main source of autofluorescence that we talk about is lipofusion, which is based out of the RPE cell. So when I look at this photograph, it's a good example of optic extrusion, but also the background autofluorescence of the RPE, which is blocked by these retinal vessels, which is why it's black. And then so we talk about dead RPE cells don't autofluoresce, they're black, they're hypoautofluorescent. And sick ones can sometimes be hyperautofluorescent. I think this is an interesting case because it's a patient of mine with central serous, and you can see the subretinal fluid here. The subretinal fluid is evident on the autofluorescence image, but it also attenuates the signal, so we're blocking a little bit of that RPE normal autofluorescence. And I'll come back to this image in a little bit. In contradistinction to that, we see another patient of mine with central serous, but you could see maybe some RPE changes here in the fundus photo, but the autofluorescence really highlights that. And this is one of the primary reasons I love to have autofluorescence in the clinic. Of course, I'd probably get a fluorescein and an ICG on this patient, but if I don't have time or if I'm in a pinch, then I can tell from this guttering, this gravity-dependent distribution of hypoautofluorescence with a ring of hyper, or that this patient's had some subretinal fluid there for some period of time. It may not be there now, but his RPE's been damaged, and he most likely has something like CSR. Of course, a choroidal hemangioma or some choroidal nevi with C and V can also do this, but again, it helps confirm the diagnosis, and it makes it really obvious, and that's a recurring theme with autofluorescence. This is a patient on hydroxychloroquine. She's got a bullseye maculopathy. This just really slaps you in the face with the diagnostics. I mean, you can't ignore this diagnosis now. Another patient with chloroquine, hydroxychloroquine history, very non-compliant in her follow-up, and you can see from her autofluorescence, sorry about that, she's got a little bullseye maculopathy there, and she did finally stop her medication.
Dr. Masson, just a quick we're always talking, especially in our clinic, about how you can use SD-OCT versus multifocal versus FAF to document toxicity. If you had to grade which one was the most sensitive or which one picked up changes earlier versus the one that was least sensitive or picked up changes?
That's a great question. So what's the most sensitive or least sensitive specific for screening? And there's been a recent article, hey Army, that's come out with talking about patients with 10-2s that are abnormal but still have normal other imaging. And that's a little bit of a gray area. In general, most people would agree that spectral domain OCT is going to be the most sensitive for picking up early findings. And part of the problem with autofluorescence in looking at chloroquine or hydroxychloroquine screening is there's a lot of operator variability. We don't actually have a trained photographer in our clinic anymore. We haven't for the last couple of years. So, basically most patients when we're using a spectralis, they focus with the infrared because it's not very bright on the patient. They don't really notice much. And then when they switch to autofluorescence, since it's a different wavelength, the focal point's a little bit different. So if they don't adjust for that, it'll be out of focus, and then it really may attenuate your signal. The other thing is you have this component of priming. So if I shine a blue light, 488 nanometer wavelength light at the retina for a long time with RPE, it's going to bring out a lot more autofluorescence than if it's really brief or if I have a small pupil. For that reason, spectral domain OCT trumps autofluorescence, and I haven't had any cases where I had autofluorescent findings without spectral domain OCT findings. Again, my N is not very big. Multifocal ERG for me is usually like a tiebreaker. There's a question, but it's not my go-to. I don't know if that's been your experience as well.
So what we've done is we typically take multifocal ERGs on patients who have just started plaquenil or who have been on, depending on at what point in their treatment they come to see us. And we've had some patients where, because we have the luxury of, in the meantime, having somebody who can do it for us.
Yeah.
And what my experience is that I've had some patients that have abnormal multifocal ERGs from the get-go.
Mm-hmm.
They've been on it for just a little bit. And so I recommend that they not even continue, even if they've just been on it for a couple of weeks or a couple of months, because I personally feel like that puts them at a higher risk. So if, it's getting harder and harder to get multifocal ERGs, so it's just good to know what your experience is on that. So we'll probably have to switch to the SD-OCT.
I like SD-OCT. Again, I don't have Dr. Harrison around the corner. I love this in my patients to him. His reports are beautiful. Multifocal ERG is not going to be quite as specific either. And that's one thing about spectral domain OCT. I'll show some images later when I get to that part. Patients can have other retinal diseases that show up so differently on OCT as compared with chloroquine toxicity or hydroxychloroquine toxicity that I'll say, I'm okay with you staying on this drug because I know you're fill in the blank. Diabetic retinopathy doesn't look anything like this. And so again, it's the specificity. Again, bullseye maculopathy, there's a lot of things that can cause it. I don't want to say it's too specific, but it is very sensitive for chloroquine toxicity. If anybody else wants to weigh in on that too, this is a pretty open forum, even though I'm going fast.
In the instance that where the multifocal is abnormal when it started, it's probably not from the plaquenil.
Right. No, I don't think it's from the plaquenil. My line of thinking is that they're at a risk for developing toxicity.
Right.
Yeah, there's a couple different approaches. One, if you can tell the difference between a different retinal process distinctly different from chloroquine, is it okay to keep them on chloroquine or plaquenil? That's one question. The other question is if they have another process, does that predispose them to earlier toxicity? And that's the bigger concern for a lot of retina specialists. So if they have drusen or something definitely going on in the RPE level, then if they're able to switch to something else, I always encourage them to.
And Dr. Harrison is going to be retiring in August, but we still have access to multifocal.
I'm glad I'm getting out of...
Through Incarnate Word. So,
through Incarnate Word, okay.
Yeah, Raven.
Oh, Jeff Raven, yeah.
Yeah, he does
Oh, I didn't know that.
Multifocals and electrophysiology there.
Okay, well, that's good to know.
We have those contacts.
Good. So this is a patient with a choroidal mass, a choroidal nevus, had been followed in clinic for a while. And I love autofluorescence on all my nevi patients to look for orange pigment. It helps me as the attending to look over the shoulder of my residents and say, okay, you're doing your due diligence, you're getting OCT, you're looking for subretinal fluid or drusen, that sort of thing. And you're getting autofluorescence in photos to look for orange pigment. So it's just one extra way. Again, autofluorescence kind of dumbs it all down so that we can all be good diagnosticians now. And so there's some hyper-autofluorescent areas here, hypo-autofluorescent to correspond to the orange pigment. This is another patient who, when they enlisted in the military, had a picture of their nevus. I can show it another time. And then 20 years later, didn't get any follow-up, came in for his retirement physical and had a small melanoma. And so then he had hyper-autofluorescence corresponding to his orange pigment. And inferior to that, you see some hyper-autofluorescence, which corresponds to subretinal fluid. So then you might ask, well, earlier you showed this patient with CSR, and we had an attenuated RPE or attenuated hyper-autofluorescence signal from this blockage of the fluid, and now we see fluid that's causing hyper-autofluorescence. There's a good reason for that. So when fluid first shows up between the retina and the RPE, it basically disrupts that normal process of shedding of the outer segments. They get phagocytosed by the RPE, and they get taken into the lysosomes and dealt with, and then that whole visual cycle is continued. When you disrupt that process, all those shed outer segments accumulate, all those fluorophores that are there, the A2E, the A2PE, those things just slowly accumulate, and then they start to autofluoresce. So you can get some sense of chronicity if you see some hyper-autofluorescent subretinal fluid. Again, different from chronic central serous in that the chronic central serous folks can have this too, but they also are going to show that guttering, and then they may not actually have chronic fluid present, so they may not have that hyper-autofluorescent fluid. This is a patient I saw with, does anybody know this diagnosis? Patient with high blood pressure, 70-year-old woman. She has bilateral retinal arterial macular aneurysms. And so I thought these pictures are beautiful. This is a patient of mine, the mom of a couple of boys that all have the same problem. They've got sticklers, and so this is just a great way to kind of show it up. This is a patient we weren't sure about the diagnosis initially, did a vitreous biopsy. She had CMV, and I used the autofluorescence to kind of follow her granular CMV. This isn't a reason to actually order autofluorescence right now, but I think in the future with diabetic screening clinics, this takes diabetic screening and dumbs it down. If you were to get wide field Optos autofluorescence on all your diabetic screening patients and they didn't have any blockage, you could probably say with some confidence they don't have heart exudates, they don't have dot blood hemorrhages. If you got OCT, you could also say they don't have diabetic macular edema. You could basically become a radiologist and take care of all your diabetic screening, which is what we've been trying to do in the military for like 2 years, and I don't know if it'll ever happen. Again, this is PDR, it's very obvious on the color, it's super obvious on the autofluorescence. This is a patient that his autofluorescence led me to his diagnosis. It seems obvious now, but back when I saw him 3 years ago, I was treating him like he was AMD, and then I looked at the autofluorescence one day and said, that just doesn't look right. Are those angioid streaks? He didn't have any, plucked chicken skin, didn't have any peau d'orange in his fundus. And then he said, well, maybe, my sister has this funny skin around her neck. And I was like, well, maybe there's something here. This is a few months later, and I focused on his nerves, and you can kind of see these do look like angioid streaks. So I said, well, you're 60 years old, don't have anything better to do. Would you mind going to my geneticist so he can work you up? And he's like, oh, sure, for you, doc, why not? So he had an ABCC6 mutation, and they were so excited, like, oh, these are all the findings of PXE. So he has pseudoxanthoma elasticum, and he still gets treatment. He's 20/20 his left eye. He's got a little peripapillary CNV there, and his right eye, saw him yesterday, he's got CNV that's pretty inactive, but he's got some atrophy that's making him 20/30. All of these patients have a mutation in the same gene. They all have ABCA4 disease-causing mutations. The one in the upper right also has a cone mutation. But I just thought these are beautiful images of what Stargardts can look like on autofluorescence and a lot of variability. So let's go on to OCT. I'm not going to rehash everything we talked about a few months ago in the lecture, but just wanted to kind of go over, there was an international nomenclature consensus on OCT, and so we are officially calling this the ELM. We're officially calling this ellipsoid zone, although ISOS won't get you jeered at. And interdigitation zone or contact cylinder layer, and then RPE Brooks CC complex. So I'm going to break down a bunch of OCTs. This is kind of like flashcards for residents, okay? So I'm just going to show a bunch. I'm probably not even going to quiz, which is what I would prefer to do, and we'll just say diagnoses. If you want to say them out loud, you can, or if you want to say that I got it wrong, please do. So this is the category of something wrong with the foveal contour. No diagnostic dilemma here, subretinal fluid, but a really bad VMT, ERM. And so I also put some blue asterisks in here where they're pretty darn near close to pathognomonic, and if Cal Mine or any of the Army Harper, anybody wants to say, hey, I've seen something else that looks like that that's not, well, this is always a macular hole, so this is so obvious. Please raise your hand. This is an epiretinal membrane. This is a few months after the peel, still has some subretinal fluid, and has too much retina in his macula type syndrome. This is a patient I saw a few months ago, had another one come in last week. Basic military trainee. Does anybody know what this is? This is going right through the center of the fovea. There's no foveal depression. What's that? hypoplasia, and she's got oculocutaneous albinism. And you can see from a retinal thickness map she has no foveal depression. And this is the category of fluid in the retina. I really wanted to go back and change this to hyporeflective stuff in the retina. I have another one that's hyperreflective, but it got too late last night. So we've got fluid in the retina. And when you see fluid in the retina residents, I want you to think about, is it an exudative process? Is it a process by which there's fluid that's pushing out into the retina and creating sort of rounder shaped spaces, because that's the path of least resistance for fluid expansion within a tissue, just like when you're blowing up a regular balloon? Or is it a tractional sort of process? Because in that case, the fluid might be shaped a little bit differently. Or is it something where you have tissue destruction? Or is it something where you get this loss of your normal intraretinal adhesion? So we'll kind of go through some of these scenarios. This, for a number of reasons, is fairly pathognomonic. You see this concavity to the sclera, so you're automatically thinking myopia, staphyloma, something like that. You even see this artifact in the upper left corner where part of the image went outside of the register and then it gets reflected back into it. Then you see a little bit of an ERM, but you see all these fluid spaces there that are fairly kind of radial in orientation. This is, a very common presentation for myopic traction maculopathy, myopic retinoschisis. It's got probably about 5 or 6 other names. This is a patient with intraretinal fluid and an epiretinal membrane. This is a very common scenario in my clinic where I get sent a patient, and I'm thinking that at this point I don't even get my hopes up, but my colleagues will say, oh, I'm sending you an ERM, it's really juicy. And I see this and I go, there's an ERM, and maybe in the old days of time domain OCT I would just peel it, but now I look at it and go, those fluid spaces are a little bit too round. It's a little bit convex. Probably if this is purely just an epiretinal membrane, it wouldn't have caused this kind of configuration. And in fact, this patient was post-phaco, and this is CME related to that, which resolved with just topical therapy. So I probably operate a lot less than I would have had I not had spectral domain OCT. It's a love-hate relationship. So this is intraretinal fluid accumulation due to a drug. The patient's actually on systemic Avastin for her metastatic breast cancer, but she's also on Abraxane. So Abraxane disrupts, I think, microtubules, and it causes them to not be able to break down in the normal way. So I don't really know exactly why she has intraretinal fluid accumulation, but she does. And when she stopped the Abraxane, the fluid went away. This is pathognomonic. Scaphoid, intraretinal fluid accumulation. I'll show you multiple different configurations of the same thing. This is idiopathic macular telangiectasia type 2 or MACTEL type 2. The way I think of this is you have loss of some of your retinal tissue, and the surrounding retina still has fairly normal architecture such that it can kind of hold that space open, or else the vitreous is sort of holding it open. They do become atrophic and collapse after a while. This is another patient, same thing, but you also see ellipsoid zone irregularities. So again, my personal theory is that this is somehow a vitreoretinal interface mediated abnormality, some sort of broad-based vitreomacular traction type thing. I have not figured out a way to experimentally prove that or disprove it. This is pretty pathognomonic. Intraretinal fluid within the internuclear layer primarily. It can appear in any layer, but when you see it primarily in the INL, you've got to think about juvenile X-linked retinoschisis. I heard somebody say it. We classically learned before we had spectral domain OCT that they had splitting in the nerve fiber layer based on a couple of pathology specimens that were submitted like in the 60s. And that still is true. In fact, if you look at this patient in the upper right, you see that kind of fist of something hanging up there. That's actually the nerve fiber layer that's been split off from the retina. And that contributes to the vitreous veils that sometimes lead to vitreous hemorrhages when they pull and yank on the blood vessels. But the fluid that we see in the retina, I don't like to call this schisis, although I do use that term occasionally. It's basically, again, loss of that Mueller cell regulation of the retinal architecture. This is the same patient. Again, you could see all those scrolling pills. Yes, ma'am.
Do you really think that it's fluid in X-linked retinoschisis?
As opposed to tissue, or?
As opposed to a separation of the retinal layers due to the lack of retinoschisis.
So that's a good question. So if we were to put a needle in one of these little holes, and one of these little hyporeflective spaces, what would we get? I don't know because I haven't tested, but I would assume that it would be a fluid, and it's probably, in fact, there's a paper that I've got on my computer where they looked at the longitudinal reflectivity profiles, basically like the quantification of the hyperreflective spaces within diabetic macular edema, within branch retinal vein occlusions, central retinal vein occlusions. X-linked retinoschisis, and they did one other thing. But what they found was the fluid, or the black, we'll call it the black spaces. The black spaces that are inside of the retina were the exact same LRP as the density of the vitreous. And their thought was, well, maybe it is vitreous gel in there. As opposed to like DME or CRVO, which are exudative processes, they were a little bit more hyperreflective, relatively speaking. They're a little bit denser. And so their thought process was, again, I can't remember the name of the authors, but I've got it in here as an IOVS. Their thought process was this is sort of a tractional or sort of, again, loss of retinal adhesion and fluid just sort of seeps in. I don't think it's a vacuum. I don't think it's air. I think it is fluid. I just don't know where the fluid comes from.
And
Do you?
the other thing is that we actually did a case series on X-linked retinoschisis patients, and we really were able to tell that the split is really in the outer plexiform layer, which is being classically thought that it was internuclear, but when we did, a lot of the kids that I see at Bascom, it turns out to be outer plexiform.
It is outer plexiform. I guess I've misread your paper. I saw one in the OSLI several years ago from BP, and I don't know if that's the one. I thought they had said internuclear layer was the most common. They said OPL? Okay, well, I mean, you were there, so you would know better than me. I've, for whatever reason, seen mostly internuclear layer. These next two are primarily, well, the bottom one's internuclear layer. The top one's got OPL, INL, and GCL. But you can see splitting everywhere. The top one's not that pathognomonic to me because you see that a lot in optic disc pit maculopathies and not so much in necessarily X-linked retinoschisis. I would say it's, perhaps a sensitive finding, but certainly not specific. So this is a patient with papillorenal syndrome, optic disc pit maculopathy, and this is a fairly pathognomonic image. Does anybody know what this is? Probably the retina surgeons do. Yeah, this is PFO. This is what I call PFO BFFs because they're going to be there together forever, and hopefully they're best friends. So I've seen them taken out, and I've seen it go really well and seen it go really, really badly.
The best I can do is just prick right over it and suck it out and try to get it lighter.
I've seen it done attempted with a cutter, and it just made me want to hide my face. All right, fluid under the retina. So not a diagnostic dilemma here. This patient had central serous. This is a patient with Best disease. This is a vertical slice. Yeah. I don't think it's fibrin. I think they're all outer segments that that are just still hanging on to the bottom of the photoreceptors that have been shed. It didn't look like fibrin on exam, but you do see fibrin sometimes in chronic retinal fluid.
If you saw this, I know that those kind of that shaggy look. If you saw this in a patient in there, let's say mid to late 50s or early 60s, no drusen, would you think about something else, or would you just call it CSR?
I get the autofluorescence and the FA and the ICG, but most likely it would be fairly fresh subretinal fluid from some cause. So C and Bs don't usually look like this. This is a pretty typical configuration for CSR. I think I've seen a choroidal hemangioma that's looked a little bit like this. But yeah, if you don't see drusen, it's really hard to call it AMD. This is a patient with VKH. We'll just kind of fly through now because I'm taking up more time than I'm supposed to. This is a patient post-buccal that's had some persistent subretinal fluid. This is a patient with a nevus and a C&V in the temporal macula. This is a patient with IMT2, again, macular telangiectasia type 2. Again, this is in the subretinal fluid, but this is, I think, just tissue loss, fairly normal foveal contour still. This is a patient of mine with acute retinal necrosis. This is a peripheral exudative RD with vitritis overlying it. Patient ended up doing fine and going to a prestigious military undergraduate institution. So something missing in the inner retina. Just a couple here. This is a patient with a branch retinal artery occlusion. You get that atrophy of the inner retina. This is a patient with Eales disease with some atrophy temporal to the macula. Choroid too fat. This is a nevus. I think this is pathognomonic, but it may not be. I just haven't seen enough. You get that kind of homogeneous hyperreflectivity just underneath the RPE in the layer of the choroid. This is the same patient with the amelanotic nevus. This is a patient with chronic central serous. This is last week, I think I took this picture. And the other eye is really active, and this eye is good eye, so I'm hoping it doesn't burst through. I don't want to do prophylactic PDT. This is a patient with VKH with a thick choroid. And this is a patient with hypotony. And 11 days later, he came back in. He said a couple days ago something just popped in his eye, and it looks a lot better now after a phaco. So this is choroid too skinny. We've only got a couple here. This is a patient with high myopia. You could see just whenever you see this irregular contour of the sclera, you got to think about that. And this is a patient with wet AMD but has a very thin choroid, and as we all know, the choroid gets thinner with age. Mixed signals, some hyper and hypo combinations. This is a patient just recently got hit in the eye. So this is a fresh, I forgot how many days prior they got their injury, but this is a little bit of Berlin edema or commotio right in the fovea. You see hyperreflectivity right there, kind of in the region of kind of the outer nuclear layer, outer plexiform layer, and then you see some hyporeflectivity in the ellipsoid. This is a patient with mudes. You could see where I put this little red circle that there's this grain out of the ellipsoid, and this is an atypical patient with mudes because they had a history of CNV. This is another patient with IMT2. Again, IMT2 diagnosis is so easy in the days of OCT. With RPE metaplasia, this is a little bit more advanced stage. That was actually a diagnostic dilemma the first time they came in when I was a fellow several years ago. This is a patient. Oh, so sorry, I just went over. RPE is covering something up, and this doesn't apply to every picture. So this is a sub-RPE fluid. This is a patient with pattern dystrophy. And this is actually, I think, an obliteration of the RPE, not necessarily a sub-RPE issue. This is a patient with a histospot who has these chronic metamorphopsias, and we always go back and forth about injections. This is a patient who has an RPE rip, and this is what they look like just a month before. And this is something missing in the outer retina, and we'll be winding things up. So when you see a patient like this, you don't just see a patient with an OCT as much as I would like to, but you see what looks like a bullseye maculopathy. You see this lossy ellipsoid zone, ELM, just in the parafoveal sort of region. If you look at the radius all the way around, they all look like that. So then you have to ask yourself why. In this patient, it wasn't a question. This is a patient with a bullseye maculopathy due to a cone dystrophy and optic nerve drusen. This is a patient with a bullseye maculopathy due to hydroxychloroquine toxicity. This is a one with choroideremia, and this one's a little bit different. They have a little bit more of an abrupt transition zone where the ellipsoid zone and the ELM sort of disappear kind of all at once. They kind of just go off a cliff, whereas usually with something like Stargardt's, there's a little bit more of a gradual change like this guy with Stargardt's. And back to our original patient, what was going on? Look at the fellow eye. This is the shark sign of really bad AMD. So, like that. I've got some more coming up. And this is a patient with retinitis pigmentosa. You see the loss of the ellipsoid and the ELM as you get further and further away from the fovea. I call it pathognomonic. It's really not. Any pigmentary retinopathy could lead to this. So I guess you could, it's within that context, call it pathognomonic. This patient also has other stigmata of the disease. Something missing in the outer retina. This is a patient I saw about 2 months ago that came in saying that he was told he had a progressive cone dystrophy, but he also had nystagmus. So probably got the wrong diagnosis from somebody else, but looks like he's got achromatopsia. He's 2150, getting along fine, 20 years old. This is a patient that liked to stare at the sun when he's out in the field. His other eye looks just the same, so he's got a solar retinopathy. He also had some other interesting features I'll have to share in another lecture. And then these are some that just don't fit any of the categories that well. This is a patient with chronic central serous. Again, a diagnostic dilemma in 2008 or 9 when I first saw this patient. And then the OCT was helpful there. This is a patient post-op, thankfully not my post-op. And of course, I did just cause one of these a couple weeks ago, but not through the macula. This is a macular fold, and here's a picture of it. I had a hard time fixing that. This is pathognomonic. Unfortunately, this is one of my patients. This was caused by hypertension, some sort of old person sort of issue. But the next one, CRAO, the next one was after a retrobulbar block, which is one of the main reasons why I use Cal-Mines Rouse needles most of the time now, because when a patient comes in with a MAC on RD like this lady did, and then she comes back out with 2400 vision when it's all said and done, you just question why, and I can't really even explain to her. I explained to her everything that I know, but the only thing I can think of is somehow the block caused her artery occlusion. So pathognomonic though, and this is a great feature. So obviously on the right you've got wet AMD, but on the left you've got this nice reticulated hyper reflective pattern on the IR, and that's dry eye. So when I see that, I give them restasis. Okay, so here's some fun OCT signs, just kind of winding up. This is from Trogshaw. one of my co-fellows. This patient actually came in on Valentine's Day with heart-shaped VMT. Yeah. There's a happy ending too. And this is the you dirty old rat sign, a patient with a nice little PED there. This is the bat sign. That's actually post-op. That's actually a good outcome. I saw him yesterday. His vision improved. He had this big plaque of pre-retinal fibrosis from a subretinal hemorrhage that had gone through a potential macular hole. So this is kind of the best we could do for him because that had happened a while back. This is the volcanic eruption sign. This is the double fundus or the uterus sign. And this last one's from Shrock, another artery occlusion. This is what he calls a bullfrog sign. So thank you very much for your time. And I wish I could stay the rest of the day. I love retina. Thanks, guys.